Hello. Okay. Well, good morning, everyone. My name is František Váša. I'm from King's College London, and I'm delighted to welcome you to this session on improving access to MRI through portable ultra-low field neuroimaging. We have a very exciting session lined up. We have had a very last-minute change of speakers, such that we only have speakers from 3 continents instead of 4, as initially planned, but still a very diverse range of speakers and topics coming up. So just to motivate what this symposium is about, I'll start by showing you a traditional high-field MRI scanner, 3 Tesla. This has a very strong magnetic field. It has very high power and infrastructure requirements. So it requires shielding, cryogenic cooling, it consumes a lot of power. It's very expensive to build and to install and to run. And it's fixed. Once it's set up, you cannot move this scanner. However, it generates very high quality data, and it gives you very nice insight into brain structure and function. There's a new kid on the block, the Hyperfine swoop. This is 64 millitesla, or 0.064 Tesla. So the field is a fraction of the field strength of a high field scanner. It comes with far lower power requirements. There's no shielding required. This scanner runs off of a standard electrical socket, so you can plug it into the wall as you would a microwave or a kettle. It's far cheaper to build and to run. And it has wheels, so you can move the scanner. You can take the scanner to the patient as opposed to taking the patient into the scanner. You can put the scanner in a truck, as you'll hear about later on, and take it on the road. And you can crucially take the scanner to new settings, such as low and middle income countries where MRI is not readily accessible. Of course, all of this comes at a cost. So the images acquired using the Hyperfine scanner are of substantially low quality than high-field MRI, and high-field MRI is definitely here to stay. This is not going to replace high-field imaging, but it can complement it in a range of ways. Another current limitation is that we can only acquire anatomical scans using portable MRI, no functional MRI as yet, and the scanner is currently head-only, although I don't suppose this audience would mind that so much. So this is work in progress, but has a lot of potential. I should highlight as well, this is currently the only commercially available ultra-low field scanner, but there's a lot of work ongoing on ultra-low field MRI. There's a lot of kind of research grade scanners, and so this is a very exciting field. And I hope to show you that actually the image quality and potential is maybe better than you might tend to think, and can also be further improved as well. So, I'll introduce myself again as the first speaker. My name is František, I'm at King's, and I'm going to show you a pilot study looking at the test-retest reliability between 2 portable MRI scanners and the correspondence of these images to high-field MRI. So we're very fortunate at King's to have not one, but multiple ultra-low field MRI scanners. We're a founding member of the UNITY Consortium, which stands for Ultra-Low Field Neuroimaging in the Young. And it's a big kind of worldwide effort, primarily funded by the Bill and Melinda Gates Foundation, which aims to place these scanners in low and middle income settings, paired with high income sites which support kind of sequence development and analysis of the data. We scanned here 23 healthy adults of a range of ages on 3 different scanners. So in the first session, the participants were scanned on a GE 3 Tesla scanner and 1 Hyperfine swoop machine. And during the second visit, they were scanned on an identical Hyperfine scanner, same hardware, same software, but at a different site. And our aims were to quantify the test-retest reliability of the ultra-low field images, their correspondence to traditional high-field scans, and ideally to be able to do this across different approaches for pre-processing and analyzing the data. So this is what the data looks like. Here I'm showing first T2 weighted scans. The default kind of stock sequence that comes on the scanner acquires images that have high resolution in one plane and a thick slice in the remaining dimension. So for an axial T2 weighted scan, that looks something like this, high resolution in the axial plane and 5 millimeters in the remaining slice. And this takes about 6 minutes to acquire. We also acquired a custom acquisition, an isotropic scan of approximately the same voxel volume as the default sequences. And we used an approach which we call multi-resolution registration. It's essentially a template building step where we iteratively co-register and average the 3 sort of thick slice acquisitions to generate one higher resolution scan with 1.5 millimeter isotropic resolution. We acquired similar data on the scanner at the other site, as well as on the high field scanner. So in this case, 1 millimeter isotropic T2 weighted scans. And we repeated all of this for T1, so we have T1 and T2 weighted scans. And we then put all of this data through SynthSeg, which is a deep learning method. It's now available through FreeSurfer. This has been trained on a range of synthetic scans across resolutions, across contrasts. It's not been designed primarily for Hyperfine data at all, but actually, as you'll see, it works very well on this data. And this gives us segmentation, including cortical parcellation into 98 structures and estimates of tissue volume. And we use these measures to quantify the test-retest reliability using intra-class correlation of tissue volumes across our 23 participants, and also the quality of the segmentation using the dice overlap within subjects of co-registered, linearly co-registered scans. We also looked at the correspondence of low field to high field MRI, again using 2 different measures of correlation, which I'll touch upon in a minute, as well as the overlap between the segmentations. And I'm going to preempt the results here by saying that our best results were obtained using these T2 weighted scans that were combined using MRR, and so this is what I'll focus on in most of the talk, but I'll highlight results for some of the other acquisitions and the other contrasts as well. So to begin, we saw really very nice reliability between the 2 scanners across tissue types, intra-class correlations of 0.98 up to 1, where each data point here is one of the 23 healthy adult participants. We looked at the overlap of the segmentation using the dice coefficient, which also shows very nice values across tissues, slightly lower values in the CSF. These values are also a little bit lower than the volume correlations, which is not unexpected because at the voxel level there might be kind of misestimates in the segmentation, an extra voxel here, a voxel missing there, that might average out when you then calculate the volume over the whole region, but very high values still. The correspondence is very nice indeed as well. So we quantified this using 2 numbers. The Pearson's R, that's the value on the left above each plot, so that quantifies the linear correlation, are the data in a straight line, and on the whole they very much are. We also measured Lind's concordance correlation coefficient, which measures exact agreement, that is the alignment of the data with the identity line, the x equals to y line. And here the values are a little bit lower, and we see in particular that we're slightly underestimating the volumes of gray matter and white matter with the Hyperfine, and we're slightly overestimating the volume of CSF. But this is effectively a constant offset, which is not such a big deal because that could be corrected for. We again looked at the overlap of the segmentations using the dice coefficient, and again, these values are slightly lower than the volume correlations and lower than the reliability, but still quite nice values there. We repeated this locally for each of the 98 structures that have been provided by the SynthSeg segmentation. and we see some variation across the brain. And I'm highlighting here the minimum, median, and maximum structure. So there's some variation, but you see the median ICC is still 0.97 across the 98 structures. For the correspondence here, Pearson's R, so linear correlation, again, some variation, but a median R of 0.96. And Lin's concordance correlation, so exact agreement of the data. Some outliers, the cerebrospinal fluid, but again, a median value of 0.9. So on the whole, very nice reliability and correspondence to high field, both globally and locally. We did local correspondence and reliability of the segmentations as well. So the overlap with the dice coefficient, again, there's some variation, but a median value of about 0.8 across structures, and correspondence to high field. Again, slightly lower than the reliability, but a median correspondence of about 0.75. So these measures are related to each other. The local maps I've shown you, you see the first two are the reliability, the intra-class correlation, and the dice overlap of segmentations. The next three are the correlation, the agreement, and the dice between the two scanners. And the final row is the tissue volume estimated on average from the high field data. And we see positive correlations here, whereby regions with higher reliability also show higher correspondence between high field and low field data. And this is the case both for the correlations and for the dice coefficient. And also larger regions show higher reliability and higher correspondence between high field and low field. It's not perhaps hugely surprising, but I think an interesting result nevertheless. So I've told you I'll mainly showcase results from T2 weighted scans, which have been combining 3 scans into one using MRR, and those are the best results. And here you see the median values across the 98 structures for the reliability and for the correspondence between low field and high field. The second best results were obtained using these custom isotropic scans, 2.2 millimeters isotropic, followed by the individual acquisitions, the axial, coronal, and sagittal scans. Now, these values are slightly lower, but still very, very high. So we see intra-class correlations of around about 0.95. Pearson's are, again, higher than 0.9. Slightly lower exact agreement, but as I mentioned, these are constant offsets that we can potentially correct. And then the dice overlap is inevitably lower than the volume correlations, but still decent results there. And now these are all the results for the T1 weighted scans. I'll just highlight these are a little bit lower than the T2 scans, but still, again, very high. So for the ICC, we see values of greater than 0.93 in the median, linear correlation greater than 0.9 for all of the acquisitions, and some decent overlap there for the segmentations as well. It's worth highlighting the T1 weighted scans have a very slightly lower resolution than the T2 weighted scans. So the T2 weighted scans are 1.5 millimeters in plane, whereas the T1 scans are 1.6, so that could contribute to that difference. And the T1 weighted scans have since been improved, actually, since this data was acquired. So this correspondence, or the difference might be smaller still. So to show you what this could be used for, we know that MRI data can be used to monitor changes in development and in aging. And you see here, even in our relatively small sample size, we have 23 adults. But because we have a nice distribution of ages, we can see changes in volume. We can see decreases in the volume of the gray matter and the white matter, and increases in the volume of the CSF across our 23 participants. And this is the case at 3 Tesla, and it's the case for the ultra-low field data as well. Not surprising given the high correspondence between the two. And you see here as well the local rates of change in tissue volume, which again are very similar between high field and low field scans. Speaking of changes as a function of age, I'd like to showcase here work by Dr. František Váša, who's a senior research fellow at UCL, who did this work together with Professor James Cole, looking at brain age in these exact data, so 23 healthy adults. And the idea of brain age is you train a model to learn the relationship between the brain imaging data and the participant's age. And once this model is properly validated, you can use that to predict the subject's age in new data from the model. And then we can look at the deviation of the subject's predicted age from their true age to see whether their brain appears older or younger than they actually are. And this has been shown to be a very useful biomarker across a range of diseases. And so Fran applied this data, different combinations of this data, so T1 or T2 or T1 and T2 scans, using different pre-processing approaches and different models. And I'm going to showcase here the kind of best performing results, which again are T2 weighted scans, super resolved using MRR, reconstructed using the FreeSurfer Reconal clinical pipeline, and combined with a model called PyBrainAge, which is trained on tens of thousands of scans, primarily biobank, but other data as well. And so here you see first the correspondence between the brain age and the actual age at 3 Tesla, and for the 2 low field scanners. And we see there's quite good correspondence. There is an offset, and this might be due to several factors, including the fact that these data were acquired on different scanners than the training data set. The pre-processing pipeline was subtly different as well. But there's a lot of potential there. And what's very nice is there's very, very high test-retest reliability still between the 2 portable scanners, and very nice correspondence between the low field and the high field. So definitely a lot of potential there to extract really some biomarkers from this data. And by the way, Fran has a poster about this, and she's here. So if you're interested, you can come talk to her about this at the end. So in summary, I've shown you that Hyperfine data, 64 millitesla, shows very good between scanner reliability in tissue volumes and good correspondence between low field and high field. It's worth emphasizing these are adults. They were very well behaved. They were very still in the scanner. The scans are of really very high quality. So you can't necessarily expect this in all data or in patients, and that's an open question. And there is work coming out already scanning patients on these scanners. This is also limited to primarily one pre-processing approach, SynSeg, and so the question is how well will this look with other analysis and pre-processing approaches. But there's a lot of potential here to leverage this data to look, amongst other things, at changes as a function of age. So thank you for your attention. I'd like to thank my collaborators and colleagues, funders for support, and I'd like to invite you to look at my poster, which is about this exact work, and also posters by Fran on brain age and by Levi, who you'll hear about in a minute, about super resolution of low field scans. So again, thank you very much. Okay, so I'd like to invite questions. There is a poll as well, which I see people are now asking questions on, or feel free to use the microphone to ask questions. I'll take some of the questions from the online poll. So how much time is each scan? This depends. This data I discussed was 6 minutes per scan, although I presented results on a scan that's combined by acquiring 3 6-minute scans and combining them into one. So that's 18. That's kind of the extreme end of the range for the highest quality data. But if you want a single scan with 1.5 millimeter resolution in plane and 5 millimeter slices, you can get that in as little as 3 minutes. The data will be of slightly lower quality than what I've shown here, but again, it very much looks like a brain. You can use it to measure tissue volume. If there's kind of significant pathology, you might well see it in that scan as well. Do you know if there's a difference compared to 3 Tesla between scan reliabilities? I don't actually, and this is one of the many things on my to-do list to look at reliability in high-field data, and I would like to actually run the same pipelines that I've ran on the Hyperfine test-retest reliability on some high-field test-retest reliability data to see what the values are and to kind of benchmark some of those results. Issues with participant motion. I didn't really have issues with participant motion so much. We used these inflatable cushions to keep the participants' head still in the scanner, and that worked quite well for the adults. We had a tiny bit of motion in 1 or 2 scans, but we were lucky in that we had very well-behaved participants. But again, these were healthy adults, and so it's a very different story potentially with younger populations or with patients. Let's have a look. Is there a rough estimate of how big something needs to be to have good estimates on the Hyperfine? Not as far as I know, but in theory, at least some of that, I think, is within the data I presented. So as I mentioned, we saw that larger structures are more reliably estimated and have greater correspondence between high field and low field. I'm wary of drawing any very strong conclusions from these data. These are, as I mentioned, a pilot study of 23 subjects, but I could imagine getting a slightly larger sample of similar data and basically using this to kind of establish confidence intervals effectively, where you measure something and you know, okay, my high field value is probably within this sort of range. Reason that T2 images give better results than T1, I answered that already. The answer is the T2 data here are very slightly higher resolution, and there were some issues with the T1 data, but this is work in progress. And finally, how much space is there to improve deep learning segmentation of low field scans? Well, I think there's a lot of scope for improvement. The results I showed here were the deep learning approach was trained on synthetic data. It wasn't designed for Hyperfine. So with sufficient paired data between high field and low field, you can train deep learning approaches certainly to do better than this. And actually, you're going to hear about one deep learning approach, not for segmentation, but for super resolution in just a minute. So thank you for your questions. Please keep asking for the upcoming talks. And I'd like to now introduce